Ali, thank you so much for joining me, my friend.
Pleasure, man.
We are doing these conversations to just talk about the background of all the incredible people that work at OS Clinic and work within it, and also just to get an insight into what it's like to be a surgeon, a professor, a doctor, however you want to phrase it, because a lot of the people at home won't know. So I'd love to get a perspective from you. How did this all start? How did you start the path of medicine?
I actually first started probably when I was 15, 16 years old, having no idea what I really wanted to be.
So, relatable, yeah.
That's what usually happens, right? And then you kind of fall into it. But there were several influences, very obvious influences. And one of them was that both my parents are surgeons, all right?
Can't get away from that one, yeah.
Now, they didn't push us into surgery, but we watched them be surgeons and grow up being surgeons. And my grandfather was a surgeon, and I hear that my great-grandfather was some kind of doctor as well, right?
Wow, legacy.
It's legacy, yeah. What kind of stops at me probably, because my son is going into math, and other is going to probably into something else. However, I saw it as a really good career, reflecting back on what my parents were doing, right? They would be excited about what they did, and I could, in the dinner side, conversation, you could hear that how they were influencing, helping people. And that rubbed off on me, and clearly rubbed off on my sisters as well. So, I'm the least qualified of the siblings, my sister is a, cardiac surgeon at King's, and the other one is an upper GI consultant at Adam Brooks. Wow. They do a lot of more fancy surgery. But that's how I guess I started. I just decided to do it. In my head, medicine was all about surgery. I could see how I became a surgeon. Mm-hmm. I was good at art, so I always painted. I was an art scholar, and I was really good at stuff like Lego and so on, right? So I had a huge collection of Lego, and I used to get Lego from all sorts of the places and build them up and take them apart, build new buildings. And there's all these little competitions that you could do with what you can build with Lego. I was all over the place. So I had a mechanical mind, and clearly right now, of course I'm a doctor, but I would probably see myself more as a mechanical engineer than a doctor, right? Of course, I'm not a mechanical engineer. I'm a doctor, right? But the idea is that what we do is a lot to do with building structures and restoring structures. It just happens to be in the human body.
Because you specialize in shoulder, elbow, wrist, if I'm
so I'm an upper limb surgeon. Mm-hmm. I've been heavily influenced by my training, where I trained, where I did my specialist training, and where I work. So I'm a shoulder and elbow guy. Mm-hmm. I do a lot of upper limb trauma, so there will be some wrist and forearm trauma that I do. But if you ask me, what I really focus on is, elbows. Yeah. Right. It doesn't matter how bad they are, or shoulders as well. And, I can, that's my thing, right?
Yeah. And, you're underselling yourself a little bit there because you work with some of the best in the world, UFC athletes, strongmen, What is it like working with people like that? And what are some of the unique problems that have come up working with those people? It's not what you can share, of course.
Yeah, of course. Most of my patients are normal people, like you and me, right? And I see pretty much patients of all ages. When it comes to kids, the very specialist shoulder and elbow problems that we see, the rest of them go to the peds orthopedics. But I have patients in my clinic that are 90 years old. They'll be city guys from the 50s. But you're right. I do see professional athletes more so than other people do. And they come from various different disciplines, right? I've seen athletes from all over, but from shoulder elbow world, I see rugby players, I see a lot of cyclists. And you'd say, why cyclists? Because cyclists in London fall over and hurt their shoulder a lot, right? Yeah. But when it comes to the specialist niche, it ends up being certain professional sports. So there are some professional cricketers, including the England first team cricketers that I have treated. But the it is mainly the fighters, the boxers, and strongmen, UFC, bodybuilders. They tend to have a lot of upper limb injuries, given the nature of forces that go through it. And I think once the reputation in the business, in the community gets there, one guy refers the next two, and they refer, so on. So I have regular follow-ups, and I pretty much know that if I have a bodybuilder coming up in my clinic, they're probably being referred by another bodybuilder that I've treated before. I feel like the surgical part of things is actually relatively straightforward, right? We are all trained to do surgery. I've been doing this for 25 years. I say an average surgeon will do a fantastic job 90 or 95% of the time, right? But what actually matters is the extra bit, right? Yes, you can always do surgery better, be a little bit more precise. Everything around it matters as well, okay? So there is always an injury, but there's always a personality behind the injury. Everybody has different needs. People say, oh, treat everybody the same, but the reality is that you can't treat everybody the same, right? You have to treat everybody with dignity and respect, et cetera, but everybody has different needs, okay? If you tear your biceps as a 60-year-old mechanic or a builder or a plumber, you may not want to have it fixed, especially if you're self-pay and you can't afford it, and you're self-employed and you want to get back to work pretty quickly. Maybe you're not having it fixed.
Yeah, because you only operate 20% of the time, roughly. Is that
correct?
Right?
Yeah. I mean, those are the numbers, but if you have a bodybuilder coming in who's a professional athlete, he's getting an operation 100% of the time, right?
Yeah.
And that makes a difference, right? So, and when these bodybuilders do come in, you have to get inside their head, okay? Because to understand what they're going through is very, very important. Otherwise, you can't treat any patients unless you understand what their needs are. And these are big guys, they're strong guys. You often don't necessarily, they don't often necessarily verbalize their emotions, but they're all going through a lot, right? You can imagine having a professional career where you're top of the game and then suddenly you tear your major tendons, your pec or your biceps. You're going to be pretty devastated, and they often are.
Yeah. And is that kind of part of your unique philosophy in terms of working with, athletes or normal people from a psychological level as well, and talking to them, knowing them, that kind of thing?
As much as a psychologist, as a surgeon, I think there's a lot of PTSD that goes with it. There's a lot of needs, and you just have to take extra care in managing that as well, because you have to put yourself in the shoes of your patients, right? I think sometimes medics can be a little bit cold and reserved, but you just have to understand, right? What is that person going through, right? What does he want, right? And if you are empathetic enough to pick that up, your patients appreciate you. Yeah,
100%.
And coming back to the philosophy of the numbers, right? 20% of my patients actually end up having an operation. Those are general numbers, and they change, but what is actually dictated by whether we do an operation or not, it's actually very simple philosophy, right? It comes down to keeping things simple. If something is not broken, please don't fix it.
Interesting.
Okay.
Yeah, because I talked about this on another interview with some of the clinicians, that they made a brilliant point. I think it was Nima that said, sometimes solutions aren't black and white binary, yes or no's, or this is it, that's it. Sometimes solutions are a spectrum. There is a choice.
They're often not binary. They're often not. There's always a choice, I think, right? And when it comes to decision making about operations, if it's not broken, don't fix it. If it is broken or torn, sometimes you need to fix it, right? But you don't always need to fix everything. Now, let's talk about very simple stuff. Somebody comes in with a collarbone injury, fracture of the collarbone. Yeah, it is broken. If it wasn't broken, you wouldn't be doing anything, right? But collarbone is broken, and what are you going to do? Are you going to fix it, or are you not going to fix it, right? And then again, in our mindset, we keep things fairly simple, right? Well, if the collarbone's broken, you're not going to heal it, right? Nature's going to heal it, right? So why are we fixing it? Well, we're fixing it for two reasons. Is it out of place enough that it may not heal? Or is it out of place enough that when it does heal, it results in poor function? And can we predict that? Okay. So a lot of times we make a decision on whether something really needs doing or not based on those things. I always tell the patients when we're making decisions about operations is that I guess you got to look at three things. Okay. First of all, you got to look at any operation that is offered. You got to look at the complications of it. And that's the easiest part to deal with because actually operations are relatively safe. People always worry about them, the complications of the operation, but the complications are so fine-tuned and so little that they need to be discussed, but that often should not be the reason why we make decisions to do operations or not. The key decision, I think, to whether to do an operation or not is to say, if I do an operation, what are the chances that this will help? And how does that compare to if I don't do an operation, how will the patient do?
Yeah.
So if you have a significant differential between the positive effects of the operation and the doing nothing, then that kind of makes your job a little easier. But if you're kind of hovering around there, in that gray area, whether you could go either way, you're probably best off not operating on people that are in that gray area.
It's an interesting, nuanced conversation, and it's going to be different for every person, right?
Yes.
I think that obviously the majority of your patients are probably going to be fairly anxious. How do you approach someone who's really nervous about what's happened to them? It could be their livelihood that is at stake because of this injury. So what's the step-by-step process you go through?
I get most of my information on what the problem is by talking to the patients. Okay, I like throwing numbers out. Probably 50% of the information on what happened, what is wrong with them, what they need, etc. By talking. We talk 50%. You have enough information. And to be honest, I mean, I've done this so many times. I probably see 2,000 new patients every year. Right. By the time somebody walks in, I can guess.
Yeah.
I was saying that that perhaps God gets really bored because the stories are always the same, right? Right? You come in and somebody says, okay, fine, let me guess what the story is. It's probably likely to be the same, right? But what is interesting is that sometimes they're not the same. So I get half my information by talking to them. I examine them. I get you kind of up to 90% by the time you've seen the patient and examined them. Anything else, imaging, etc., all that stuff is just the icing on the cake. You probably already know what's wrong. That imaging often is just to rule out once in a while there's a surprise, etc. So when it comes to actually offering patients something, right, we actually really have to hone down on what their needs are. Elite athletes are a classic example, right? Okay, elite athletes is not about necessarily them doing a straightforward desk-based job and they want to get back to and so on. Their career or livelihood is online. Completely different matter. So often we make a decision on whether we need to operate or not just on the probabilities of non-operative treatment. So for example, if I have a professional footballer and we have a few that come in and dislocate their shoulder. Often when you dislocate their shoulder, you'll rehab them and just make sure that they do well or not. And sometimes they do really well with just rehab. But we know probabilities, right? We know that if you are young, male, athletic, you have a very high chance after your first dislocation of dislocating again, right? So we pretty much know that if you're a 17-year-old, there's near enough a 90% or 100% chance it'll come out again. But in the normal population, if you have your own kid, my kid is 17-year-old, I will want him to take rehab because there's a 10% chance he'll be all right. I want him to get through his A-levels, etc. And if his shoulder becomes a problem, we can always fix it later. Yeah. However, it's very different for an elite athlete, right? Elite athlete is like, you can't take that 10% chance to say if he's going to make it or not.
Yeah.
When there is a 90% chance or more that if you do fix it, he'll be fine, right? So we kind of flip it around, right? So for elite athletes, the decision is very different, we fix them because we cannot afford not to fix them from their career point of view.
Agreed.
So everybody's different.
Yeah.
Right.
How much does this differ when it comes to treating women? Is it basically the same case, or do they? Is it kind of a different approach?
Absolutely the same. Absolutely the same. Right. Women have the same needs as men. They'll be different from each individual. So we treat them in the same approach. Okay. So an elite athlete that is a woman is treated the same technique, same ways as we would do a man, right? Okay. We have enough bodybuilders that are women as well. Oh my God. And some of the women that do ultra high marathons and so on. Some of the sports differ, of course. I don't see a lot of women cricketers. I don't see as many women rugby players, but we see a lot of hockey injuries.
Yeah.
Okay. Yeah. So it differs. Yeah. But yes, the philosophy is the same on how we treat people.
Yeah. Because are there any common injuries, afflictions, things like that you see quite often that people could actually easily avoid in their life? When it comes to what happens in sports, you can never quite know what's going to happen in a game, a match, or a competition. But just for general advice at home, is there something you're like, every day I see that and I wish I could just tell the people this? What would it be?
So elite athletes tend to have proper injuries that are often non-avoidable. Okay. But if you're talking about normal people, weekend warriors and so on, one of the things that there are people who are like us in the 40s and 50s and 60s that behave like 16-year-olds, right? All right. So I've been going to the gym with my 16-year-old, not as often as he does, right? And it's a little bit of a competition, right? Just making sure that he can't lift as much as me. But week on week, he just piles on the muscles and he lifts more reps and so on. And they're very different. He doesn't do any warm-ups or any warm-downs or as much as he should, right? He's very controlled, but it's very different. Now, that mentality needs to change when you get in your 40s and 50s. There are significant changes that happen in people as they get older. Put it simply, every part of our body is always healing and breaking at a microscopic level. All right. Your skin is changing around, your tendons are changing around, as even your bone, the tiny cracks appear and they heal. The whole thing about stress fractures is when you are breaking slowly at a higher pace than you're healing, and suddenly the bone gives way. Now that capacity to heal, it decreases over time. So we see common injuries like, tennis elbow or cuff injuries slowly build up and suddenly become a problem after, somebody's been doing something for months and months at a particular age where you wouldn't necessarily get them when you were a 16-year-old.
Yeah.
So just appreciating that our bodies do change. I strongly encourage at every level for patients to remain active. My mom still lifts, my dad still boxes, and dad's already 80, mom's going to be 80 in a couple of months or a month or so.
Yeah.
And you just got to do it, right? Because bone density, muscle mass, etc., is a great sign for living longer, right? It correlates very highly with a good, healthy lifespan.
Yeah.
So I encourage that. But how we do those certain things is important, right? So a really good hydration, good warming up, good warming down, making sure your supplements, including vitamin D and so on, is optimized, and making sure that you take enough nutrition like protein and so on. It gets harder and harder as you get older. Right. So I tell patients you have to spend as much time warming down and warming up as actually doing the lifting.
There's two interesting things there, because obviously everyone knows they should warm up. As you move from your 20s to your 30s, you probably get into it a bit more.
And the elite athletes do.
Yeah. And you need to, because all the pros do, you should do the same. But I think people often, warm-ups are you either like run on the spot, or people are very leg focused when it comes to warm-ups. Do you see people often forget the warm-up of the upper body as well, especially if they're playing tennis or something?
I've seen people turn up on a tennis court and just swing their legs around a little bit and start playing tennis.
Basically, yeah.
And really hurt their shoulders after a while and saying, why do I have a rotator cuff syndrome or impingement? Why do I have tennis elbow, etc.? It happens a lot.
what are some of the best like warm-up stretches to do? So is it, I know there's dynamic warm-ups, there's static stretches, what's the best order if we're putting together a kind of a pre-game setup? And this is going to be different per sport, but let's imagine this is tennis.
No fucking idea. It is, yes. So I do particular stretches and so on. For some of the sports that I do. I play a little bit of basketball and
excellent.
But yeah, it's a great sport.
Yeah, we should hoop sometime.
Yeah, we should. Yeah, I'm not as good as I was when I was 16.
Hey, you never lose it, man. You never lose it.
But again, when I go to the gym and so on, I do a lot of my stretches and so on. But the idea is to do it, right?
Yeah, so whatever you do is good. It doesn't necessarily need to be the perfect scientific thing, as long as you're just doing your best and you feel.
And warming down is good as well. People forget to do the warm downs.
I must admit, I do ignore warming down.
Yeah, done the gym, just stumble out.
Yeah,
right,
so literally
in the cold weather.
5-minute walk on the treadmill was enough. Like, what is a warm down? Like, what is this class as? Is it just...
Yeah, exactly.
Doing something less intense before you end. Is that basically the gold standard?
It is, and just doing your stretches again. So I do especially with my legs and so on. I kind of do the stretches again. Otherwise, you can get DOMS. The delayed onset muscular pain that you get. Right. So
yes. And for athletes and just for normal people as well, because strange things that I've noticed, if I don't have a shower directly after the gym, I'm gonna get that soreness. But if I shower quickly after, I tend not to. Is there any real scientific basis in that, or is that just what works for me personally?
For what, on basis on what? Sorry,
if it's a gym workout, if you just make sure you get yourself warm water, because I know there's cold water versus hot water. Yeah. What's the best kind of treatment for that? If you're really trying to put together the optimal plan for after I've trained, what do I do?
Yeah. Don't know, quite honestly, right? So
whatever works with the individual.
Yeah, it does. Yeah. So for me, I just feel like when I go to the gym and so on, is the only time that I have a hot shower, and then I like to have a really cold shower afterwards as well. There's enough evidence to suggest that a cold plunge or a cold shower improves healing rates, right? It kind of releases something evolutionary in your body to kind of improve a healing rate.
Yeah. Okay.
We can leave that out of the podcast. Bit awfully.
No, that's absolutely fine. I think it was really interesting anyway. I mean, going back to looking at certain things, common industries, right? So this might be the interesting time to look at a bit of a rapid fire round.
Sure.
So I've gathered some questions from the general internet.
Yeah, and we can talk about rotator cuffs and shoulder dislocation.
100%.
Biceps
that's definitely on the list.
Yeah.
But the goal is to see how many we can answer 60 seconds at a time.
Okay, fine.
Are you ready?
60 seconds per question.
Yes.
Okay, fine.
Yes, not all in one go. A rotator cuff tear always requires surgery to heal, yes or no?
The answer is definitely no, right? Size of the rotator cuffs, which is often described in literature, actually doesn't matter. What matters actually is the location of the tear. So if I look at rotator cuff tears, I divide them into two different beasts. One is the degenerative wear and tear that often happens very slowly as you get older. You'll see them on scans. They're often not a problem. If they are, you can sort them out with conservative treat, very rarely surgeries. Completely different beast if you have a 45-year-old who gets his arm pulled or yanked off and tears his cuff.
Yeah.
Got to fix those ones, right? Yeah. Because they don't do well. So generally speaking, the rotator cuff only needs to be fixed if it's a traumatic one, and in the degenerative one, they're not always a problem. Very common after the age of 60. Something like 40 to 50% of the patients over the age of 60 will have a rotator cuff tear. Wow. And I call them wrinkles. We often say, what's the word? Gray hairs, cuff tears.
Okay.
Go together, right?
All right, we've got to remember that one. Yeah. Tennis elbow. If you have tennis elbow, is the best way to treat it, rest it and just not move it?
The answer is no. So first of all, tennis elbow used to be called, and probably is still called generically, lateral epicondylitis. Itis suggests that this is inflammation, but we know that tennis elbow is unlikely to be inflammation, is often not an inflammation. So you've got to start treating tennis elbow like an injury. It is again a microscopic collagen disorder, that small little injuries pile up. So to help tennis elbow heal, you have to reverse it. You have to heal at a faster rate than you are kind of breaking down. So the key is, how do you heal? Of course, resting, icing, etc. is important. But if you just rest it and if you don't load the elbow in a certain way, it will not heal as well. So there are certain exercises that we do which are really helpful for tennis elbow, particularly eccentric stretching exercises that can help the collagen, which is like all haphazard, kind of put it almost straight. That's how I like to imagine it, right? And those work. The key is to do very specific controlled loading and appropriate rest that goes with it. So what I'm saying is that you got to do your stretching exercises, you got to do the eccentric loading, you got to slowly build up so it heals. But at the same time, you can't just suddenly go out on a tennis court and start hitting rounds and expect that it will be fine. It won't, right?
100%. Okay. Next one. Frozen shoulders will eventually thaw out on their own. True or false?
If the black and white answer is true or false, the answer is true.
Okay.
But we also know that the typical mantra that a frozen shoulder is freezing for 6 months and is frozen for 6 months and then thaws out for the next 6 months, taking an 18-year period, may fit most people. But there are certain people, around 12 to 15%, that even after 5 years can be stiff and in pain. So again, not everybody is the same. There are always outliers. Now, treating frozen shoulders is an interesting philosophy. Some people will say, well, if it's going to thaw out, why are you treating it, right? But it is one of the most horrendous, painful conditions that also causes significant dysfunction, not only from the pain, but also from the stiffness. And I just feel that in today's modern world, it feels wrong to have somebody suffering for 18 months on average and not do something about it.
That is a long time.
So for frozen shoulders, the philosophy is that if you have pain and stiffness from a frozen shoulder and you've confirmed this, do something about it. Most frozen shoulders do not need a surgery. In fact, my personal figures, and I only see the tip of the iceberg, are probably less than 8% end up requiring surgical intervention. We can treat most of them with physio and specific injections.
Interesting. Okay, so feeling numbness or tingling in your hands at night, is that the sign of some kind of trapped nerve, or is it most likely just laying on your arm roll?
Bit of both, actually.
Nice. Okay.
So if I had to choose, of course, it's a trapped nerve, right? But that trapped nerve could be just temporary on something that you have slept on funny, right? So you can always sleep on, pressure on your radial nerve that can let your wrist go numb, and you can have a wrist drop. So, but of course, right? If it's happening at night, then it is suggesting that something is predisposing the nerve to get squeezed at nighttime more than daytime. Now, the classic one is tennis elbow. Beg your pardon. The classic one is carpal tunnel.
Yes.
And the ulnar nerve. The ulnar nerve is what we now call the iPad elbow, right? And I'll come back to the second. But in carpal tunnel, why is it more pronounced at right? Well, there are many factors, but one of the things that happen at night is we tend to go into fetal position when we sleep. And if you're holding your hand like that, you can compress the median nerve, resulting in carpal tunnel. And then you get the typical pain that at nighttime, you wake up, you shake your hand, you drop your hand, and then it gets better. Similarly with the ulnar nerve, if you sleep like this, it squeezes the nerve. Okay? And it can cause problems as well. So we can get dynamic compression at nighttime of certain nerves that results in pins and needles. But if your answer is pins and needles and numbness, are there a sign of compression? Yes, there are.
Okay. The next one's going to be an issue and probably something that everyone's experienced. If you have cracking and popping in your shoulder or elbow, does that mean you have arthritis?
No, I just cracked my knuckles, right? That does not mean I have arthritis, right?
What is that sound?
Well, there's a lot of debate about it, right?
Okay.
But it's often thought about as tiny little bubbles of air or something kind of gliding over. It could be just some of the ligaments and so on moving over certain joints, right? But what we now know is somebody tested this apparently, that they made somebody crack their knuckles on one side for many years, and not the other side, and there was no difference in arthritis and so on. So cracking knuckles does not result in arthritis.
Sure, that person was
apparently.
relieved. Yeah.
Relieved after is a very useful study after doing it for many years.
Okay.
Now, the cracking of the joints could be for many reasons. It's often not arthritis. If you get that grinding and crepitus, that could be. But certain cracking when you're popping and so on happens for many reasons, right? One of them is that you have, again, joints, ligaments moving over each other and they kind of crack, right? It could be that something is slightly unstable, a ligament is torn, or a biceps is slightly unstable and kind of flicks over certain things. That's usually it. Very rarely is it arthritis.
Okay. Another question for you then. Shoulder pain, is it most usually from the actual joint itself? Is that where most shoulder pain derives from?
No. Right. So if somebody presents with shoulder pain, and we often see people coming up to our clinic saying, I have shoulder pain, we ask them where the pain is. Right. Now, if you have pain on the top of the shoulder here, right there, quite often is very specific to a joint called the acromioclavicular joint or the AC joint, the joint at the end of the collarbone. Okay. If you have pain that refers from your shoulder beyond your elbow, think about the neck. It could be your neck because the neck nerve pain can pinch and refer pain all the way down to your arm. If something goes to the back of your shoulder, around your scapula, your wing blade, again, think about the neck because you could have a referred pain from your neck. Most of the shoulder pain, for some reason, is always down here.
Okay.
There is some arthritis pain that can go in the back of the shoulder, but generally speaking, very non-specific, most pain is down here, the anterolateral portion of your shoulder or the front and side of your shoulder.
Okay.
But it could be for many reasons. And if you ask me, where do most people get pain from? What pathology? First of all, young people with ligament injuries, dislocations do not get pain. Ligament tears often don't result in pain. Very rarely they do. So the commonest types of pain that we see, right, if I was to guess, is patients presenting with frozen shoulders, very, very high because they have a lot of pain all the time. Frozen shoulder is a very benign condition, but hurts more than most tears and so on. But then you have rotator cuff tears. You have, before that, you'll have impingement or inflammation or tendinopathy of the cuff that can result in pain as well. So those are the common things. But, typically speaking, the real reasons for shoulder pain that somebody says, I'm complaining of shoulder pain, that's why I'm here to see you, will be like a frozen shoulder or a rotator cuff tear. Arthritis in the shoulder, luckily, is very rare.
Okay. On that same point, this is the last of the rapid fire round. We've talked a lot about what a frozen shoulder is. Can we redefine what a frozen shoulder is? Because it's actually the first time I'm hearing of it in terms of a condition, and why is it so painful, and how can people prevent from getting it, or is it potluck who can get it?
Yeah, it's so much research always changing on the frozen shoulder word. So first of all, I like analogies, and I like to give one here. So when I talk about a frozen shoulder and try to explain it to a patient, I try to tell them that this is a very painful condition, makes your shoulder stiff and painful, and you're miserable, and often patients are very anxious about it. But we have to then reassure them that actually the shoulder structurally inside is normal. What we have to think about is to explain to the patient that every joint has a lining. The inner lining, the capsule, and think of it as a lining of the suit. It could be really thin, and it's often really stretchy like Lycra. Very, very stretchy, can let you do whatever you want in your shoulder, right? Now, something triggers it where that lining of your shoulder changes and becomes stiff and thicker. So you're going from Lycra into a thick, leathery structure, right? Okay. And that makes your shoulder stiff. And obviously, with that inflammation that comes with it, you have pain as well. So the take-home message from that is that something changes in that. Now, what happens? Now, in Japan, the frozen shoulder is called a 50-year-old shoulder. So the average age is a 50-year-old man or woman getting it. But women get it at a much higher rate than men do. And there are certain predispositions. So if you're a diabetic, you probably get it 5 times as much as a non-diabetic, even if you have reasonably good control. right? Bad control perhaps makes it worse. Thyroid disease, a lot of other autoimmune conditions have it, right? So there are certain patterns to it. And nowadays we are seeing a huge reason to believe that there may be a correlation, not just a causation, with menopause as well. So
Okay.
of course it happens around the same time as most women are going through menopause, but we're now looking deeper into actually, is there an underlying issue as well? Now, there is some evidence that women who are in HRT get less frozen shoulders or less intense frozen shoulders. We know that estrogen and so on influences the elasticity of capsule and so on. We know that changes in hormones can affect other conditions, autoimmune conditions like insulin resistance, etc. So even though menopause may directly in some cases cause it, but indirectly the hormonal changes can affect other stuff like insulin resistance and so on, that results in a lot more perimenopausal women getting frozen shoulder.
Okay, interesting. And just in terms of the future of how we do this stuff, there's always new research techniques, robotics coming into surgery, right? Tell me a little bit about how things like stem cells are being used in shoulder treatments and things like that now, especially for arthritis.
So stem cells are not really being used that much for shoulder arthritis yet. I mean, there is a lot of shoulder arthritis out there. And you know, one often thinks everything to a hammer looks like a nail. And that is not what we should be thinking.
Okay.
So one needs to have a very holistic approach to everything, right? There are stem cells advocate or biologics advocate, including PRP, that say they can fix everything with that. I've had people in the rehab world saying we can rehab everything out. And I have surgeons who will say we can fix everything. But the reality is somewhere in the middle, okay? And again, to simplify things, rehab is important for everybody. Let's just get that out of the way, right? Then when it comes to everything else, if you look at biologics, they're really good for biological healing, improving regeneration and so on, but they're not going to fix the mechanical problems. If your rotator cuff is torn and fallen 3 centimeters away from where it should be, it's not going to magically put it back in. Now, a rotator cuff, think about it. I describe another analogy to the patients. I describe as a rotator cuff tear to the patients as imagining that you have a curtain in your house. And the curtain, the muscle is the cloth of the curtain itself. The tendons are the hooks, and the railing is a bone that is attached to.
Yeah, okay, interesting.
All right, now, what about a tear of the tendon? A tendon or tear is when 1, 2, or more hooks come out. Do you really care about some hooks coming out? Well, you may do, right? So when would you care? Well, if 1 or 2 hooks come out in the middle and nobody else notices, including you, nobody really cares. So if you have a small tear in the right position of the rotator cuff, then you don't need to worry about it, right? It's balanced. There's good mechanical support on either side. But if too many hooks come out, or interestingly speaking, if you lose a hook on one end, then the curtain droops. And then you pull on the curtain, and after a few little pulls, the next hook goes, the next hook goes. The rotator cuff exactly like that, right? There's nothing different about it. There's no magic to it. If you have a rotator cuff that tears on one corner where it needs to be attached, and it progressively can get worse as well. So when it comes back to the thing about stem cells or fixing things, well, figure out what the problem is, right? Mechanical problems sometimes need fixing. And once they are fixed, they may need biology and so on to enhance healing. So we often use PRP, platelet-rich plasma and so on, to improve the healing rates. Okay. In tennis elbow, there's not a tear to fix often, and rehab is good enough with appropriate exercises, but it sometimes doesn't work. There is enough evidence to say platelet-rich plasma induces a healing rate in tennis elbows. When it comes to full-on stem cells, there are lots of voodoo magic out there, and there's a lot of people pretending that they have stem cells and so on. It is not being done in UK in a legitimate way. But there are 1 or 2 institutions that actually have been doing it for 20, 30 years with proper FDA clearance for their cells, who have so much data that you can rely on certain conditions to help.
Awesome. It was good because, my preconception is, like you said, stem cells are just like this new magic that solves everything, right? So it's good to clear that up. And I suppose this rounds things out really nicely because I want to talk about general advice. What piece of wisdom can we impart to people to keep their elbows and shoulders healthy so they don't have to see you?
This is actually really simple, right? Okay, you got to look after yourself.
Yeah.
Okay, and nutrition is a huge part of it. Okay, so start with nutrition. Make sure you have enough protein. Make sure you have less processed food. Okay, it sounds very simple, but that's where it starts, right?
Yeah.
Okay, make sure you optimize with your minerals and vitamins. Now, the classic one is vitamin D. If you live in this country and you do not take vitamin D, I can put money on the fact that you will be low in vitamin D.
Yeah.
Right. And the ranges of vitamin D that are normal published are barely needed. So 50 to 100. So if you're less than 50 is low, but 50 isn't great either, right? Right? To optimize your functions, you need it a lot higher as well. So most people should be on vitamin D. And we know that it has so many other benefits, right? It improves every function in your body. It protects you against viruses and colds and so on, etc. Even COVID, with people with good vitamin D, had less severe disease as well.
Yeah.
So nutrition, including, is very important, I think. That's where it starts. The second most important thing is regular exercise. Okay, you gotta do regular exercise, whatever it is, whatever. Okay?
What is regular class as in a week?
I would ideally suggest that you're doing it once a day.
Okay.
Whatever it is, right? You do your 7,000 to 10,000 steps, right? But once or twice a week, at least lift something, right?
Okay.
Right. So resistance exercise is key. Aerobic exercise is fine, but resistant exercise, you got to be able to put that in because you got to maintain your bone density. You got to maintain your your muscle mass as well. That is the best sign of protecting you against any diseases, keeping you active, and more importantly, making sure that you get old and stay healthy when you're old. The last thing that you want is that you are an 80-year-old that can't mobilize. It's not a good life, right?
Yeah.
So nutrition followed by exercise. Then it is basically sleep.
Yeah.
Yeah.
It's all the stuff we know we should be doing, but
I do all
we
three of them
struggle with.
really badly.
Yeah. Yeah. It's always
but
the way.
I try.
It's always the way.
I try. Sleep is so important.
Yeah.
Right? Sleep is your best medicine.
Yeah. Sleep is a miracle. And I'm sure
Yeah.
we could probably do a whole episode on sleep just in regards to the benefits and things. But
then everything else is the icing on the cake, right? So look, modern medicine is very important, right? So you can do all of these things, and modern medicine can help you live longer. If you didn't do all of those things, then modern medicine struggles, right? But let's be very realistic as well. Modern medicine is the fourth component after that if you need something, right? It goes to show the life expectancy from 10,000 years ago to 200 years ago went from 30-something to 35-something, right? I don't know the exact figures.
yeah.
But over millennia, you only increase your life expectancy by 5 or 6 years. And now we have a life expectancy to 80 that we've achieved pretty much in the last 40, 50 years. Seems to be dropping a little bit in some parts of the world, thanks to processed food and so on.
Yeah.
So modern medicine has a massive influence. We can't do everything. You got to do your first 3 things first.
Incredible. And then that's the message for people trying to keep the pain away.
Yes.
For those who are living with pain and might be quite wary or even just scared of surgery, what can we tell them just to put them at ease or even explain a little bit of how it works?
If somebody has pain, I think there are 2 messages. First of all is you got to figure out what the reason for the pain is. Okay, you got to find out. Okay, find the right person who tells you why you have pain. Sometimes there are issues that can be fixed with or without surgery, so you don't need to live with pain. Sometimes there are things that can make your pain better. But once in a while, as long as you know the cause of the pain and you accept it, that kind of makes it okay as well. Okay, so you got to figure out why you're in pain, because there's a lot of anxiety that comes with pain, not knowing. Classic frozen shoulder, very simple problem. Half the people I tell them that is easy problem, they don't worry about it anymore, right? Okay.
Yeah.
I can't remember what the second thing was, right? But the what was the question again? What that was?
It was just imparting, someone who might be scared of surgery,
Yes.
But definitely needs to do something. What do we tell them?
Yeah, so exactly. So figure out what the pain is, and then a good doctor will guide you whether you need surgery or not. Now, you can't shave away pain by doing some magic surgery, but there are certain pathologies that cause pain that can be helped with. But figuring out is the first thing. The second thing is that what people are often afraid of when they have pain is stop doing what they're doing. Okay? And I would encourage people that when they have pain to keep moving, keep lifting, keep doing things that, and not stop. Okay? This thing about if you have pain, just completely stop doesn't seem to work. I have sometimes back pain, okay? And the best thing I can do when I have back pain is not do nothing, which I want to do, is actually go in, I do a lot of stretches, and I do a little bit of lifts and so on, and somehow I feel better. It's not for everybody. Of course, I know that my back pain is not something that requires injections or surgery and so on. It probably requires me to lose a little bit of weight from my tummy and get some better abs.
You and me both, brother.
Right, right. So, but the thing is, there are solutions there.
Yeah.
And when it comes to doing certain things, when people say, oh, I have pain, should I lift or not? I normally know what their problem is. And my guide to them is usually, if there's something that you can do exercise-wise and it's not hurting you, please do it. If there is something that you can do that hurts you a little bit, still do it, right? Especially if it's something that goes away after you finish doing the exercise. But perhaps try and avoid something that makes you a lot more sore for many days or weeks.
Okay.
So a very simple thing,
Yeah.
It works.
Excellent. And then last but not least, we need to talk about, obviously, your work is integral at OS Clinic. It's a group of incredible individuals that have come together to form something greater. Tell me what that's been like to be a part of OS Clinic, the work you do there, and just give us a story.
So the OS brand as such was probably founded, in 2012, 2013. And I got one of my colleagues to join. It was very difficult to convince people to join a new group when there are already many established groups. And it's also difficult to stick to your ethos, which was, we want the best of the best. We could have made the group massively huge straight away, but we didn't. We resisted. We wanted the right people who are good clinicians in every way, compassionate, good at what they do, and who want to genuinely join us for the same vision. So it was only two of us. It was myself and Nima. Nima joined very soon after I started it. In a few years later, we formalized it, and we had 5 of us. Okay, we then worked with various different hospitals and so on, and people saw the value. People saw that there was something great that was coming out of it. Okay, you have people that are driven by outcomes, driven by passion, who will not compromise on patient care and so on. We always thought about the long term. Always all about how we want to be treated if we were patients ourselves, and how we want to do our profession in the best possible way. And it's been organic, right? So it was me, and then it was Nima, and then there was nobody else for many, many years. I call it bacterial growth in a nice way, right? And then suddenly there'll be a little bit more, right? And there were 5 of us. And then there were, for many years, there were not many more, and there were 10 of us. And I think there were well over 30 right now. And all really good people, right? I could, these guys see my mother and my dad and my 2 boys as well.
No,
right?
that's trust.
Oh, so of course it is, right? Everybody's handpicked, and is trusted and does the right thing. So I'm very proud of it. I don't think there's anything like this and anywhere else in the world.
Incredible. And Ali, this conversation has been amazing. If people need to get in contact with yourself, where can they find you?
Everywhere.
Everywhere.
And nowhere. Right. Of course, the best way to find me is you can go on the OS website. I have a little bit of a social media presence as well. Very happy to be reached out.